Hey guys, today I want to talk about dysphotopsias. Dysphotopsias are really bothersome for patients after cataract eye surgery. And what a dysphotopsia is an unwanted visual problem or phenomenon that's usually due to the design of the intraocular lens itself. Basically, the light comes in, catches the lens, and scatters in a way that is not physiologic, not normal. As a result, people have funny visual phenomenon, usually on the edge of their vision. And I want to share a case with you. I had this very nice lady. She had Odyssey lenses placed in both eyes. She's thrilled with her right eye, but her left eye, she just cannot get over the dysphotopsias, even after waiting months and months and months, which is usually what I recommend first, is just time. Time can be very therapeutic for these. They tend to get better. It just wasn't getting there. And she was having a tough time being outdoors or being in bright environments because the light was causing all this scatter, and it was very bothersome to her. So I knew it wasn't a lens problem in and of itself. She liked the Odyssey lens in her right eye. The issue was just some scatter effect that she was getting on the left, which is very common. I've seen this and others have too, where the left eye tends to get more dysphotopsias than the right. She also had a little bit of a hyperopic prescription, which means she was a little plus on that eye. So if I can take the lens, which is currently in the bag, and move the optic or the circle part of the lens forward in the eye, I could correct two things at once. One, I can make her less hyperopic and help her see better in general. And two, I can reduce or hopefully eliminate her dysphotopsias by shifting the whole optical system forward. So I've created a little video for you here showing how I do it. First step, I'm going to open up the old cataract wound. It's been about 6 or 7 months since her surgery. Usually around 6 months, I don't try this. I just make a new wound, but I thought, hey, let's see if I can open it up. So I'm taking the Donnenfeld spatula and just easing my way into that space, moving it back and forth. And it actually opened up nicely, no issues here. I didn't show it, but I also made a paracentesis wound, 2 of them, and injected some viscoelastic. I use Helon GV. So here I'm taking the Donnenfeld spatula and gently placing it between the optic and the anterior capsule lip. This creates an opening so that I can then put a Helon GV cannula into that space and start dissecting the lens away from the baggie. As the eye heals after cataract surgery, the baggie sort of shrink wraps around the lens. So you need to open up and spread out that shrink wrap so that you can easily move the lens into its new position. So I'm taking my time. I'm being very careful here. I do not want the bag to split open. I want to maintain its integrity as much as possible. And I first start by getting the optic freed, and now I'm going in and targeting the haptics, which are the little legs on the lens. And I just want to make sure that the lens is nice and freed up from the shrink wrap so that when I move it, I don't tear the shrink wrap, so to speak. So I've lifted the lens up. I feel pretty confident that it's free enough to do this little maneuver. While it's flipped up, I'm going to take my INA and clean up some of the posterior capsule and remove the viscoelastic or a good portion of it from behind the lens. The capsule didn't look very opacified, so I did a more conservative polish here. And now I'm taking a Conner wand and I'm lifting up the optic edge and easing it towards me to get it up over that lip. Okay, I feel pretty confident it's up over that lip. Now I'm going to ease it over and then tilt up the opposite portion of the optic and push it over. And I've done it. I performed reverse optic capture. The optic is in front of the lips of the capsular bag, and the haptics are still in the bag. So right here, I'm just kind of confirming, after I cleaned out the viscoelastic, that I didn't accidentally dislodge or move the lens. I did not. You can see it's sort of subtle, the edge of the anterior capsular rhexis that I made previously. On day 1, the patient was 25-ish, 20-30, J1. And she was so happy. The dysphotopsias were already gone and she felt like she had her life back. So it's really important to create a good size capsular rhexis, about 5 millimeters, nice and circular, so that if you do need to do a reverse optic capture down the road, it's ready to go. You don't have to worry about that. I didn't mention this, but she also had a little bit of a hyperopic prescription prior to surgery. So by moving the lens forward, I kind of corrected for that and gave her a little minus and corrected 2 things with one action, meaning I both corrected her prescription and made her more myopic, which is good, And I got rid of her dysphotopsias. So 2 birds, 1 stone. I didn't need to remove the lens that I already had in there and replace it with a different lens that you can reverse optic capture. Although that is another way to do this, would be, okay, it's such a miss in terms of the prescription. I can't correct that with ROC, so I'm gonna take out the lens, put a new one in, do the calculations right for sulcus placement, and put in that new lens. All right, I hope you enjoyed this video. Be well.